let's look at the management algorithm for patients presenting with sexual dysfunction in the context of antidepressant treatment. We know that there are specific types of sexual dysfunction that can be associated with certain antidepressants, and antidepressants can affect various phases of the sexual response cycle. In this particular algorithm, we take sexual dysfunction as an overall entity, but as clinicians, we must delve into further detail to identify which phases have been affected. Is it reduced libido, erectile dysfunction, orgasmia? Is it decreased vaginal lubrication, etc.? If there is sexual dysfunction, consider using a valid scale like ASEX, which is the Arizona Sexual Experience Scale. The next step is to identify whether the patient has major depressive disorder. If they don't have major depressive disorder and they have sexual dysfunction, then a proper medical evaluation becomes essential. In addition to the medical evaluation, a psychiatric history becomes important. As part of this evaluation, physical examination, investigations such as hormonal levels should be carried out and appropriately treated if there are abnormalities. Generally, in the context of sexual dysfunction, in the absence of antidepressant use or in the absence of major depressive disorder, agents such as phosphodiesterase 5 inhibitors are used, such as sildenafil, tadalafil, vardenafil, but also agents such as flibanserin, which is specifically used in hypoactive sexual desire disorder in females because it acts through the dopaminergic and noradrenergic pathway. Bupropion is also considered outside the depressive domain. In this group, if the medications do not work, psychotherapy, relationship counseling, sex therapy, etc. may be considered. On the other hand, if the individual has sexual dysfunction and major depressive disorder, the next question is, are they on an antidepressant? If they're not on an antidepressant and they are depressed, then one must consider the possibility that depression itself is leading to sexual dysfunction or most certainly exacerbating it. In this situation, initiation of low-risk antidepressants such as agomelatine, desvenlafaxine, moclobamide, trazodone, vilazodone, or tioxetine can be considered as first line. Alternatively, mirtazapine, duloxetine, and levomilnacipran are also agents that may be considered second line in the context of major depressive disorder and sexual dysfunction. Once initiated, consider follow-up and using scales such as the ASEX to identify improvement. Next, if the patient is depressed and they're on an antidepressant, one must always consider the possibility of treatment-emergent sexual dysfunction. At this stage, it becomes important to try to establish temporality. Has this sexual dysfunction started specifically after the antidepressant, or was it pre-existing and worsened by the antidepressant? Because there are slightly different approaches for both. If this is not considered treatment-emergent sexual dysfunction, then review antidepressant choices at this stage, and one may add an antidote such as the PDE5 inhibitors, as mentioned earlier, sildenafil, tadalafil, vardenafil, or flibanserin in females or bupropion. If this is treatment-emergent sexual dysfunction, then one may again consider augmentation with the phosphodiesterase 5 inhibitors, sildenafil, tadalafil, vardenafil, flibanserin in females, and bupropion. So very similar approaches to both. If at this stage the sexual dysfunction is still unresolved, then switching the antidepressant to an antidepressant that has a lower risk or minimal risk of sexual dysfunction should be considered. Agents such as agomelatine, desvenlafaxine, moclobamide, trazodone, vilazodone, and vortioxetine should be at the top of the list. If the sexual dysfunction is still unresolved, psychotherapy, relationship counseling, or sex therapy should be added on top of this medication treatment.